Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Assessing Readiness for Substance Use Disorder Treatment and Employing Appropriate Harm Reduction. And our presenter is Dr. Kelly Ramsey, Associate Chief of Addiction Medicine for New York State OASAS. She will be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's disorder treatment professional. As always, if there are any questions or comments or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now, it's time to start the presentation and welcome Dr. Ramsey.
Thanks, Dean. I'm going to start us off with the learning objectives for today's talk. They are the following: understand readiness for treatment versus motivation for change, understand self-efficacy and resilience, understand the use of motivational interviewing to support change in patients, and understand how to employ harm reduction strategies depending on the person's stage of change. So first, a quote and some food for thought. People are better persuaded by the reasons they themselves discovered than those that come into the minds of others. And that is by Blaise Pascal. So just a little background before we get into the meat of the talk. Many people who use drugs do not recognize fully that they have harmful use or that their problems in life are secondary to their use. Many people with drugs say they want to stop using, but don't know how, or are unable to, or are not fully ready to stop. So what is the historical approach to substance use disorder treatment? And I call this the stick. These are some ideas that have been part of the history of our treatment system. Change is motivated by discomfort. If you make people who use drugs feel badly enough, they will change. People have to hit bottom before they are ready for change. Someone who continues to use is in denial. The best way to break through the denial is through confrontation. Effectively, people don't change unless they have suffered enough. You better or else. If the stick is big enough, no carrot is needed. More food for thought. And this is a quote by William R. Miller, PhD. Strong evidence suggests that direct, forceful, aggressive approaches are perhaps the least effective way to help people consider new information and change their perceptions. Such confrontation increases the very phenomenon it is supposed to overcome, defensiveness, and decreases clients' likelihood of change. So let's look at a better approach to substance use disorder treatment, and you can think of this as the carrot. People in general are ambivalent about change. People who use drugs continue their substance use because of their ambivalence. All change contains an element of ambivalence. Resolving ambivalence in the direction of change is a key element in motivational interviewing. Motivation for change can be fostered by an accepting, empowering, and safe atmosphere. Person-centered approaches enhance motivation and reduce risk. So why don't people change? It is not that they don't want to see, denial, or that they don't care, no motivation. They are just in the early stages of change. So how do people change? Change is a natural process, and treatment can facilitate that process. A person's perception of how likely it is that they can make a particular change is a good predictor of whether the actual change will occur, i.e., the person needs to believe in the change, and the provider or counselor or facilitator's belief can become self-fulfilling prophecies. What comprises readiness? So readiness is a multidimensional concept that incorporates several constructs, including the following: problem recognition, desire for help, desire to change, treatment reluctance, such as fear or privacy concerns, and treatment readiness. What influences treatment readiness? And there are several factors here as well. Predisposing characteristics, so these are static, unchangeable attributes of individuals, such as gender, race, ethnicity, age, education level, and treatment history. Illness factors, overall health beliefs, perceived value of receiving treatment, tangible barriers such as lack of transportation, inability to pay for care, or lack of child care, severity of substance use disorder, and legal involvement. Inhibiting factors, circumstances in the overall environment that interfere with health-related actions. These are mutable, changeable characteristics which affect mental and physical health, social relationships, and employment, such as depression, social support, familial influences, having a trade, or employment status. Couple more quotes. What is motivation? Motivation can be defined as the probability that a person will enter into, continue, and adhere to a specific change strategy. And that comes from the Council of Philosophical Studies in 1981. And a more modern version, motivation to initiate and persist in change fluctuates over time, regardless of the person's stage of readiness. From the client's perspective, a decision is just the beginning of change, and that comes from Miller and Rolnick in 2013. So what is the historical view of motivation? That it is a static client trait, that either the client had it or the client did not have it. The provider, counselor, facilitator has no influence on it. The view of motivation as static led to blaming clients for tension or discord in the therapeutic relationship. Clients who disagreed with diagnoses, did not adhere to treatment plans, or refused to accept labels like, quote, alcoholic, unquote, or, quote, drug addict, unquote, were seen as difficult, manipulative, or resistant. So what is a more modern concept of motivation? It is a key to change. It is multidimensional. It is dynamic and fluctuating. It is influenced by the provider's, counselor's, facilitator's style. It can be modified. It is the facilitator's task to elicit and enhance motivation. And, quote, lack of motivation, unquote, is a challenge for the therapeutic facilitator's skills, not a fault for which to blame our clients. So as I mentioned, motivation is multidimensional. Motivation includes clients' internal desires, needs, and values. It includes external pressures, demands, and reinforcers that are both positive and negative that influence clients and their perceptions about the risks and benefits of engaging in substance use behaviors. Two components of motivation predict good treatment outcomes: the importance clients associate with changes and their confidence in their ability to make changes. So is the client ready, willing, and able to make changes? Ability refers to the extent a person has the necessary skills, resources, and confidence to make a change. Willingness is linked to the importance a person places on changing, how much the change is wanted or desired. Ready represents the final step in which a person finally decides to change a particular behavior. Our task is to help the client become ready, willing, and able to make change. So now I'm going to go into a couple of concepts that are important to understand their role in readiness for treatment and motivation for treatment. So I'm going to talk about self-efficacy first. So self-efficacy is the belief in one's capabilities to organize and execute the courses of action required to manage prospective situations. Self-efficacy is a person's belief in his or her ability to succeed in a particular situation. And those quotes come from Albert Bandura. Confidence is a nondescript term that refers to strength of belief, but does not necessarily specify what the certainty is about. Self-efficacy is having the confidence in one's ability to deal with a situation without being overwhelmed, and that comes from Hira. So if we look at Bandura's self-efficacy theory, it has several influences that affect perceived self-efficacy and that lead to possible outcomes. So some of the influences on self-efficacy include the following: performance accomplishments, vicarious learning, social persuasion, and emotional arousal. The possible outcomes are persistence, performance, and approach versus avoidance. So the social cognitive theory of self-efficacy has several factors which determine efficacy judgments. So let's talk in more detail about those specific influences that Bandura was talking about. So first, let's look at vicarious experiences. So people can develop high or low self-efficacy vicariously through other people's performances. A person can watch another perform and then compare their own competence with the other's individual competence. So again, that is vicarious experience. What about physiological feedback? People experience sensations from their body, and how they perceive this emotional arousal influences their beliefs of efficacy. Verbal persuasion. Self-efficacy is influenced by encouragement and discouragement pertaining to an individual's performance or ability to perform, and performance outcomes. Positive and negative experiences can influence the ability of an individual to perform a given task. If one has performed well at a task previously, he or she is more likely to feel competent and perform well at a similarly associated task. So these are some of the important elements that determine a person's self-efficacy. So this is just an example of showing a person who has high self-efficacy. So the female in both pictures has a good self-image and has a perception of having high self-efficacy. In the picture on the right, she sees herself as a superhero. And the gentleman on the left-hand side has low self-efficacy. So you can see all the papers piled behind him on the desk, and he doesn't know how to handle this task and is overwhelmed and does not have an image of himself as being effective in doing whatever the task is that he needs to get done. So that's the first concept that plays a large role in both readiness and motivation. The other concept that plays a large role is resilience. So let's talk about that. The gentleman on the left seems to be overwhelmed by whatever's going on in his computer and is not feeling, again, effective. And in the second picture, you can see that the person who moves from I can't do it, I want to do it, how do I do it, I'll try to do it, I can do it, I will do it, is more likely to achieve success. So what is resilience and how does it play a role here? Resilience is the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress, such as family and relationship problems, serious health problems, or workplace and financial stressors. Psychological resilience is the ability to mentally or emotionally cope with a crisis or to return to pre-crisis status quickly. Resilience exists when the person uses mental processes and behaviors in promoting personal assets and protecting self from the potential negative effects of stressors. And that comes from the APA. So when and how is resilience built? So it's complicated. So there are genetic factors that contribute significantly to resilient responses to trauma and stress. So on the left-hand side, when positive experiences outweigh negative experiences, a child's scale tilts towards positive outcomes. The initial placement of that fulcrum in that seesaw affects how easily the scale tips toward positive or negative outcomes in the future. So in the graphic on the right, how stress affects your child's brain. So challenges, adversity, and failures lead to stress, which actually causes a physiological response of increased cortisol and adrenaline that are released. And when you're in that fight or flight behavior, your prefrontal cortex, which is the thinking part of the brain, actually shuts off. So essentially your rational thoughts, your organized thoughts, your self-regulation become inaccessible when you're in a complete stress response. So again, what are these genetic and epigenetic factors, and how do they play a role here? So there are multiple genetic factors that affect resilience. So there are diversity of genes and polymorphisms that are associated with myriad axes in our physiological responses, including neuropeptide Y, the hypothalamic pituitary adrenal axis, the noradrenergic, dopaminergic, and serotonergic systems, and something called brain-derived neurotropic factor. So these are all hormones and neurotransmitters that play a role not only in our fight or flight stress response, but also in our vulnerability to developing substance use disorder. There are also epigenetic factors. So these are functional modifications to the genome. So they don't actually change the genes, but how the genes work. So again, they do not change the genetic sequence, but epigenetic factors result as a consequence of exposure to stress-related factors during critical periods of development. So you put together these developmental and your environmental factors that affect our ability to be resilient. So for an adolescent example, who is trying to respond to a stressful situation, there's a role that sex and gender play, that genetics play, epigenetics play, perhaps some other form of inoculation, HPA programming, which again is that hypothalamic pituitary adrenal axis, and other factors. If we look at the picture all the way to the right, that is showing sort of the larger societal and structural environment that add, again, to this resilience response. So when we progress from pre-adolescence through adolescence and young adulthood, not only do we have everything that's going on a physiological level in our own bodies, but we have a school environment, a family environment, a neighborhood, an economic, political, and cultural environment, and a structural environment in society that all play a role in our resiliency. So despite the fact that genetics and epigenetics do play a large role in resilience, even for those who are less resilient from a genetic and epigenetic perspective, resilience can be built, but that requires us having a village around us of positive persons who can help instill resilience in us. So if we look at the graphic on the left, it's showing some of the things that happen when someone builds resilience. So this can be from having positive role models in school environments, in healthcare environments, in your home or family. So you learn self-esteem, you learn from your mistakes, you understand and accept your own strengths and weaknesses, you develop self-control, you have a willingness to overcome difficulties rather than to avoid problems, you have optimistic thinking patterns, you have social skills and social ability to seek assistance from others. You can see that these are some of the things that I mentioned earlier for making people ready and motivated for treatment as well. Ability to recognize your own emotions and those of others, so the ability to have empathy. Problem-solving skills, goal setting with realistic expectations. All of these things are components of resilience. On the right-hand side, if we look at a modern definition of resilience, it is advancing despite adversity. So it's goal-oriented, it's working towards a vision, it's proactive. So again, it's not waiting for all the obstacles to be moved out of your way, but being proactive about the results that you want. And it has both large and small everyday challenges. So the 6 domains of resilience include vision, having purpose, goals, and congruence, composure, being able to regulate emotions, recognizing interpretation bias, and being able to be calm and in control, reasoning, so having problem-solving skills, resourcefulness, and anticipating and planning appropriately, health, so having adequate nutrition, sleep, and exercise, tenacity, so having persistence, realistic optimism, and the ability to bounce back when obstacles occur, collaboration, so having support networks, so these would be healthy support networks, social context, and being able to manage perception. So this leads me into what are the vulnerabilities for developing substance use disorder? So genetic predisposition is the bulk of our risk. So it accounts for 40 to 60% of our vulnerability to develop a substance use disorder. If we have concomitant mental health diagnoses, particularly bipolar disorder, any form of anxiety, major depression, ADHD, specific personality disorders, including borderline personality disorder and antisocial personality disorder, that can make us more vulnerable for developing substance use disorder as a coping mechanism. Having a history of trauma and/or abuse, so particularly for females, pre-adolescent sexual trauma, and then for both males and females, being a victim to or a witness to violence or trauma. Having poor coping mechanisms and escapism can factor into developing a substance use disorder. Impulsivity, and that can be just because of lack of development of the frontal lobe. So our frontal lobe does not become fully developed until age 25. So again, impulsivity is going to be in existence more so in persons who haven't fully developed their frontal lobe, in addition to being present in some of the mental health diagnoses, such as bipolar disorder and borderline personality disorder. Sensation and novelty seeking plays a role in initiation of substance use, but again, that tends to trail off as people develop substance use disorder. Environmental triggers or sensory cues are triggers to use or resume use. So it could be that someone shows up at your door holding a bag of heroin. So it's a visual cue that triggers you to use or move down the pathway towards reward in your brain. And then a lack of homeostatic reward regulation, so reward deficiency. So when people begin to use, the brain becomes primed with an orientation towards pleasurable rewards and larger dopamine surges that occur with the use of substances that are not physiological. So for example, the pleasure that someone gets from sex or from food cannot compare to the pleasure or the dopamine surge that is derived from heroin or particularly methamphetamine. So when you prime the brain with early substance use, you are actually reorienting the balance of neurotransmitters in the brain, and you're changing both anatomical pathways and physiological balance in the brain. So adverse childhood experiences play a role in everything that I've talked about thus far. So again, the ACE score is comprised of noting abuse, so physical, emotional, or sexual abuse, neglect, either physical or emotional, household dysfunction, including mental illness in parental figures, an incarcerated parent, a mother who is treated violently, substance use in parents, and divorce between parents. So the impact of ACEs has a very real effect on health outcomes. So again, looking at from conception at the bottom or base of the pyramid all the way up to the top, which is an early death, we can see that those adverse childhood experiences influence health and well-being throughout the lifespan. So again, it can contribute to generational embodiment or historical trauma, social conditions with a local context, and adverse childhood experiences can disrupt neurodevelopment, as I mentioned, with early substance use, and that can have social, emotional, and cognitive impairment that occurs, which leads to adoption of health risk behaviors, including substance use, and that can lead to disease, disability, and social problems, and ultimately an early death. So let's get into the trans-theoretical model or look at the stages of change. So the stages of change are represented on this wheel because someone can move back and forth between stages. So those stages are pre-contemplation, contemplation, determination, action, maintenance, and relapse or resumption of use. And again, there is an opportunity for permanent exit, but many people stay within the wheel of change. So what is the concept of ambivalence? So ambivalence is normal. People usually enter treatment with conflicting and fluctuating motivations. People want to change, but they don't want to change. So working with ambivalence is working with the heart of the problem. So what is motivational interviewing? I have a couple more quotes, and these are both from Milner and Rolnick. MI, or motivational interviewing, is a directive, client-centered method for enhancing intrinsic motivation for change by exploring and resolving ambivalence. And that's from 2002. Motivational interviewing is a way of being with a client, not just a set of techniques for doing counseling. And that's from 1991. So what are some general motivational strategies? They include the following: giving advice, removing barriers, providing choice, decreasing desirability, practicing empathy, providing feedback, clarifying goals, and active helping. And here you see someone moving up the steps of behavioral change. So in pre-contemplation, the client is unaware of the problem. In contemplation, the client is aware of the problem and of the desired behavior change, but is not ready to make a change yet. In preparation, the client is intending to take action, but has not taken action yet. In action, the client is practicing the desired behavior, and maintenance is when the client is working to sustain the behavioral change that they have already made. So what is the spirit of motivational interviewing? And it has several components: partnership, acceptance, compassion, and evocation. Partnership means that the partnership is between the client and whoever is working with them. So it is done for and with a person. Acceptance is profound acceptance of whatever the client or the person before you is bringing to the table. Compassion is commitment to pursue the welfare and best interests of the client. So again, it's not the facilitator's best interest or welfare. It is the welfare and best interest of the client. Evocation is recognizing that the person in front of you, the client, has what they need, and together you will bring it forth. So it comes from within the client. So the mindset and the heart set of partnership, acceptance, compassion, and evocation is a firm foundation for better communication about change. So what would motivational interviewing look like when we're putting it into practice? So one component is expressing empathy. So here's an example. It must be very difficult for you to talk about your heroin use and how it has affected your relationship with your daughter. Developing discrepancy. It sounds like, on the one hand, you want to stop using so you can see your daughter, but on the other hand, you like the way heroin makes you feel. Adjusting to resistance. I hear you saying that abstinence isn't for you right now. Supporting self-efficacy and optimism. You have obviously given this a lot of thought and have some great ideas on what may be useful to you. Avoiding argument and confrontation. I don't think you have failed because you are here and you want things to be different. So again, thinking about the spirit of motivational interviewing. Planning is talking about how. Evoking is why. Why do you want to make a change? Focusing is where. Where do you want to focus? Engaging is how shall we take this walk together and help you get to your goals? And these processes can be linear or recursive, and they can be ongoing. So some more on the spirit of motivational interviewing. So it explores clients' perceptions without labeling or correcting them. It is not about teaching, modeling, and skill training. Resistance is seen as an interpersonal behavior pattern influenced by the facilitator's behavior. Resistance is met with reflection, not more resistance. It's being non-judgmental and collaborative. It's based on the client and the facilitator partnership, not one being in dominance over the other. It is gently persuasive. It is more supportive than argumentative. It listens rather than tells, and it communicates respect for and acceptance for clients and their feelings. So what are some principles of person-centered care within motivational interviewing? Services exist for clients. Change is self-change. People are experts on themselves. We don't have to make change happen, and we don't have to come up with all the good ideas. again, we should rely on our client to do that. Some more of these principles. People have their own strengths, motivations, and resources that are vital in order for change to occur. Change requires partnership. It is important to understand the person's perspective. Change is not a power struggle. Motivation is evoked, and we cannot take away people's choice about their behavior, even if we disagree with it. I think that's a really important concept to remember in person-centered care. So how do we avoid some common traps in motivational interviewing? So first, the assessment trap. That's when the assessment is at the beginning of the relationship and service, and the relationship stays within the context of that assessment and doesn't move or mature as the relationship moves and matures. There's the expert trap. So we, as the facilitator or the counselor, we do not have all the answers for our patients without their collaboration and expertise. So we should not be seen as the expert or think of ourselves as the expert. The premature focus trap. So this is often exploring things of concern to the patient leads back to the topic of concern for the counselor. So again, we need to remember who is in care, and it's our client. And so it's important that we focus on what's important for our client and not, again, what is the counselor's concern. The labeling trap. So again, we might be worried about making a diagnosis and we get stuck in our diagnosis rather than letting things evolve as the relationship evolves. The blaming trap. So blame really is irrelevant here, so it's important that we not get caught in a cycle of blaming. And this one is my favorite, the chat trap. In one treatment study, higher levels of in-session informal chat, so in other words, the better the casual relationship you have with your client, predicted lower levels of patient motivation for change and retention. So I think of it as patients who maybe don't want to make a change are great distractors, and so will bring little, chatty things that they think you might want to talk about into their session. But it's really important to remember why we're there, and it's not to make a friendship. It's to try to help somebody affect change. So what are some obstacles to effective listening in motivational interviewing? Warnings and threats, trying to persuade with logic, arguing, and lecturing, asking too many questions and not listening, ordering and directing, and giving advice, making suggestions, and providing solutions rather than letting the client formulate their own thoughts about the situation and perhaps make suggestions and provides their own solutions to what's going on. Affirmations are an important part of motivational interviewing. Affirmations do the following. They appreciate a strength or a positive action. They should be true and genuine. They should express positive regard and caring. They should strengthen working alliance with the patient or client. They should diminish defensiveness. And affirmations include commenting positively on an attribute, a statement of appreciation, catching the person doing something right, a compliment, or an expression of hope, caring, or support. So good affirming usually centers on the word you. You were struggling with this, but I really see that you've come to peace with it in the last week since I saw you. Motivational interviewing also includes a change plan. So the change plan might include some of the following phrases. The most important reasons why I want to make this change are, my main goals for myself in making this change are, I plan to do the following things in order to accomplish my goals and include a specific action and when that might occur. These are some possible obstacles to change and how I could handle them. So writing the possible obstacle for change and how to respond to that obstacle. Other people could help me change in these ways and mentioning a specific person and possible ways that they could help. I will know that my plan is working when I see these results with the specific results listed. So counseling depends on the person's stage of change. This is where I frequently see people bumble, including medical providers, et cetera. They're not recognizing where the person is in their stage of change, and then they're instead trying to pull them where they want them to be. So there's a mismatch of the counseling for the person's stage of change. And if you don't match your counseling to the person's stage of change, the person is not listening. So it's really important to understand these key points. So what is happening in pre-contemplation? You're trying to create awareness for change in values and beliefs. So in pre-contemplation, the person is not ready to change. They are not currently considering the possibility of change, and they may be resistant to change. So the most important role that we have is listening to the patient, really hearing them, hearing where they are at, instilling hope so that they don't become despondent about where they are, even though they don't want to change, provide choices for where they are now. So for example, if someone is actively shooting heroin, you can provide choices by giving them harm reduction advice on how to do that safely. So again, you're not pushing them where they're not ready to go. In other words, they're not ready to stop injecting and they're not ready to stop using, but you're letting them know where they can go to a pharmacy and purchase syringes, or that their medical provider could write a prescription for syringes, or where they could go to a syringe exchange program. And you're providing sensitive feedback. So for example, if the person who, again, is not ready to stop using shares with you that their sharing works with somebody else when they're injecting, then you can provide sensitive feedback that they're putting themselves at risk for HIV and hepatitis C, and again, use those points around harm reduction to help them do what they're doing more safely at this point in time. So the next stage of change is contemplation. And the point of our role here is to persuade and motivate. So in contemplation, this is characterized by ambivalence. The person who considers and rejects change is willing to consider the problem and the possibility of change. But again, contemplation is not a commitment to change. It definitely comprises both reluctance and resignation. So our role is to work towards resolving ambivalence, explore the issues and examining the consequences, discussing past change attempts in an attempt to increase self-efficacy. So again, an example here would be someone who, they see that their cocaine use is complicating their life and it's causing some problems in their life, but they really still enjoy using cocaine and the effects that it gives them. So this is a person that you would want to talk about, think of it as the box with 4 squares, and you would want to talk about the positive things that the person gets from cocaine use and the negative things that they get from cocaine use, the positive things that they could possibly see from stopping cocaine use, and the possible negative consequences that they see of stopping cocaine use. And again, by working through each of those 4 squares with the person, I would imagine over time, if the person is moving towards an action stage, then they are going to be seeing more negative than positive with their cocaine use. So the next stage is planning or preparation or getting ready for action. So in this stage, the person's statements sound more motivated. They're sort of moving towards a stage of preparation. They have a commitment to change, but it doesn't mean that the change will be automatic. So again, in this stage, all ambivalence is not necessarily resolved, but this is a window of opportunity. People may remain in this prepping stage for a very long time. So they're kind of sitting on the fence. So our role here is to assess strength and level of commitment, help determine their best course of action, match the motivation with the change strategy, and prepare them to do what will be required to do. So for example, somebody who's thinking about starting MOUD or medication for opioid use disorder, but they're still actively using, you would spend a lot of time talking to them about the 3 different approved FDA medications, and you would look at what that would mean. So for example, if the person were most interested in methadone, then they would need to go to an OTP or an opioid treatment program. If they were interested in buprenorphine, there are a variety of settings where they could obtain buprenorphine. If they're interested in naltrexone, the same. There are a variety of settings where they could access naltrexone. So it's really an informative time for the person, the counselor, facilitator, or the medical provider to really share information with the patient to help them make the most informed choice possible. So the next stage of change is action. So in this stage, the person is actually engaging in action to make a change. This change requires building a new pattern of behavior, which typically takes 3 to 6 months. And return to use is always possible. So formal counseling may or may not assist in these efforts, but what we can do is help reaffirm decisions and focus on the successful activities that they have done thus far, and help them identify and use strategies and coping mechanisms to prevent return to use. So this is a great time to use something, a tool like a recovery support plan with a patient. So talk about specific persons and places and things that could trigger resumption of use in someone, and developing strategies on how to deal with either those triggers to use or environmental cues and triggers. So the next stage is maintenance. So in this stage, a person attempts to sustain change accomplished by previous actions and to prevent return to use. Slips are also common in this stage, but if not dealt with, they can lead to a full-scale return to use. Change can also become habit eventually, and then less vigilance may be required, but some vigilance is still always required. What I found with my patients previously, if patients have no vigilance at all, then often complacency sets in, and then folks may be more vulnerable to return to use. So in this stage, we want to teach change and help clients know what to expect, and help them identify and use strategies to avoid return to use. But someone who I've found is healthfully in their maintenance stage, they will share with you when they slip. And often a slip, they'll note when it happens, they recognize why it happened, and they're able to resume their maintenance by being able to rely on supports around them, whether it's you in the counselor facilitator role, or whether it's with a family or friend or somebody from the recovery community. So that's an example of the maintenance stage. So in the return to use or recycle stage, this is a full-scale return to previous behavior with no pretense of continuing the change. So the patient surrenders, and they don't any longer believe that they can do it. They're in the I can't do it phase. So the person's task is that they literally have to go back to the beginning and start over and move through the stages of change again. The facilitator's task is to help the person avoid discouragement and demoralization, continue contemplating change, renew determination and preparation, resume action and maintenance efforts. The process of change is rarely the same in subsequent attempts, but the person has the knowledge that they've gained from those previous attempts. It's really important to not contribute to a person's own discouragement and demoralization at themselves. It's really important that you remain positive and that you help encourage them rather than discourage them. Often our clients have so much internalized stigma that they feel a lot of shame when they have a resumption of use. And it's very important to not contribute to that, but to encourage their self-efficacy and remind them of the successes that they've had and their ability to do it again. So let's look at some clinical considerations. So as I'm sure everyone is aware, harm reduction is an evidence-based practice that can be utilized within the spirit of person-centered care. So let's look at some specific examples. So the person sets the direction of the process. I don't want to stop using heroin, but I don't want to die. So in this example, you could give or prescribe, if you're a medical provider, naloxone, and you can advise them regarding or provide them in some setting with fentanyl test strips. As people may be aware, the federal government recently stopped the prohibition of federal funds being used for the purchasing of fentanyl test strips. So that could be part of your strategy with your patients who are actively using. And again, regardless of what drug they're using, if they're using anything that they purchased on the street, it could have illicit fentanyl added to it. So a person may not know that they may be at risk for an opioid overdose due to illicit fentanyl, for example, if they're a stimulant user. However, we've seen a huge rise in the increase of stimulant deaths because of fentanyl added to the stimulant supply. So it's important that we educate our patients regardless of what their substance use disorder is and prescribe or give naloxone. So goals are set that are most important to the person. I am going to use heroin with other people around me and use a clean needle each time. So in this situation, again, a medical prescriber could prescribe syringes to reinforce that client strategy and or give information regarding local syringe service programs or that the person can purchase syringes in a pharmacy. The person's strengths, abilities, and preferences are highlighted. You have created a plan that will allow you to use in a safer way. So the New York State Department of Health has created a document. It's a handout, a pamphlet that's called Build a Safety Plan, and that can be ordered at the website shown there for free. So what does harm reduction mean for people who use drugs? It is meeting people where they are at. So it's not forcing people who use drugs to be where you want them to be, and it's not leaving them behind if they don't live up to what you're expecting from them. So it's meeting them where they're at and giving them appropriate advice to decrease their risk with whatever actions they're doing currently. Harm reduction lies on the treatment continuum with active use at one end and perhaps sustained abstinence from all substances on the other end. So one thing I think is important to remind people is that there is a stage of change for each substance that someone is using. So someone may come to you and they may be in the action phase with respect to their heroin use because they're worried about overdosing and dying, but they may be completely pre-contemplative with respect to their cocaine use. So it's important to recognize the stage of change for each substance that someone is using and then apply appropriate counseling for that stage for each drug. The next concept is that change is positive. So embrace it, and that helps encourage self-efficacy and resilience in our clients. So be sure to give an affirmation regarding any positive change that our clients are able to make. So keeping patients alive is harm reduction. So using buprenorphine intermittently to decrease heroin use is harm reduction as it decreases the risk of death by overdose. So i.e., dead drug users don't recover. That comes from the Iowa Harm Reduction Coalition. So I think we need to remember that by addressing our clients where they are at and helping them decrease their risk, particularly for dying, by employing that strategy, we are going to help people trust us and get to a place where they're more likely to hear the other things that we may be saying. If we don't help them to survive, they're never going to make it to recovery. So the first point is helping people survive. So we should always be asking people about their substance use. So again, regardless of what setting you're in, including in a primary care setting, assume that substance use is occurring, so normalize it. If you're asking a question in a way that you expect a no to your question about substance use, that's probably the answer you're going to get. People are very good at reading who's asking them the questions and what they're expecting. So if a person is giving a vibe of, I really hope this person is not using any substances because I don't have time to go into it right now. For example, in a primary care setting, 15-minute appointment, then the person's going to get the vibe that I'm not going to share anything, and they're going to say no, and then you're not having an honest conversation. It's really important to ask non-judgmentally with curiosity. Curiosity is fine if it's done respectfully and non-judgmentally, and be aware of your face and tone. I've actually heard people ask people if they're using by saying, "You don't use drugs, do you?" Now, what is anybody going to answer to that question except for no? Don't necessarily expect people to be honest with you at first. You have to earn trust. So people are really afraid of being stigmatized against, and people who use drugs have been stigmatized against in healthcare settings. So they're going to be leery, and it's important that you, again, treat them respectfully and non-judgmentally and let them open up with you. And once they've earned your trust, they're far more likely to share their story with you. And the last point is just remember to listen. Everyone has a story. I read a statistic that the average physician interrupts a patient every 7 seconds. If you're interrupting a patient every 7 seconds, then they can't tell you a story. And that's what's really important, is learning how to be still and how to listen, because then folks are far more likely to share with you how they got to where they are today. And just a reminder that for the first time in 2019, the USPSTF, the United States Preventive Services Task Force, recommended that all adults in primary care be asked about substance use on a yearly basis. So another reminder that recovery is individualized. So a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. That's the definition of recovery, and that's going to look different for every person. So the elements that comprise that individualized recovery include health, home, purpose, and community. So when we say health, we mean overcoming or managing one's diseases or symptoms. So for example, that might be somebody who is Hep C positive and is feeling really negative about that, and perhaps they're not ready to address their substance use, but they are ready to get treated for their Hep C. You treat their Hep C, they cure, and then they achieve the self-efficacy to address their substance use. So again, by treating acute health issues and helping people improve, that may help them actually in achieving recovery. Having a stable and safe place to live. Many of our clients are unstably housed or unsafely housed or homeless. And so it's very difficult for someone to prioritize recovery when they don't have a stable and safe place in which to put themselves on a daily basis. So helping people achieve safe and stable housing is a really important part of their journey. And I think the two perhaps most important components are purpose and community. So purpose means having meaningful daily activities and the independence, income, and resources to participate in society. If someone doesn't see their life as meaningful or their life as purposeful, it's going to be hard to have a reason why recovery is important. So it's helping people see their inherent self-worth and helping them cultivate either things that they want to do or things that they already are good at, and encouraging that in them, and then helping them find a support system around them to support that purpose, and that's a community. So often our folks who come into care with us have no example of healthy relationships in their lives historically. So they often have codependent relationships or just unhealthy relationships. So it's helping them create relationships and social networks that support them in friendship, love, and hope, and in their recovery. And once you've helped them achieve these four things, they're far more likely to be able to pursue a meaningful recovery for themselves. So ultimately, our goal is wellness. And wellness, again, is multi-dimensional. So emotional wellness is coping effectively with life and creating satisfying relationships. Financial wellness is having satisfaction with current and future financial situations. Social wellness is developing a sense of connection, belonging, and a well-developed support system. Spiritual wellness is expanding our sense of purpose and meaning in our life. Occupational wellness is personal satisfaction and enrichment derived from our work, however we define our work. Physical wellness is recognizing the need for physical activity, diet, sleep, and nutrition. Intellectual wellness is recognizing creative abilities and finding ways to expand knowledge and skills. And environmental wellness is good health by occupying pleasant, stimulating environments that support well-being. And you can see that a lot of these factors sound similar to the components of resilience. So in conclusion, readiness for treatment is a complex, multidimensional concept involving multiple, often opposing domains. So it is not necessarily predictable when a person will be ready for treatment. Motivation is multidimensional, dynamic, and may be elicited by effective motivational interviewing. Self-efficacy and resilience are key components underlying motivation and effective change. And counseling and harm reduction interventions must be tailored to the person's current stage of change. So here are some resources on opioid overdose prevention. We created these during COVID-19. So there's an OASAS video on overdose prevention. There's a landing page with many resources regarding overdose prevention. And then you can always call our 24/7 Hope line, either with the toll-free number or by texting. And if there are any questions about this presentation, in addition to using the Learning Thursday mailbox, you can certainly use my email address. And I really thank you for your time and attention, and I'm going to turn this back over to Dean.
I want to thank our presenter, Dr. Ramsey, for today's program. I hope you will all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we're meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us and keep up the good work.